So yesterday we had a look at the pneumonia, definition of pneumonia, the pathogenesis of pneumonia, different causes of pneumonia. Also, we had a look at the different clinical presentations of different types of pneumonia. Also, we had a look at the workups of pneumonia. So today we are going to look at the management of pneumonia, because it's good after diagnosing something is good to manage or to prevent. And also we are going to look at the complication and even some prevention measures that can be taken in order to prevent pneumonia. So let's see the management of pneumonia. So the first thing we'll talk is about antibiotic. Earlier on we saw that 65% of pneumonia is caused by a bacteria, that's a streptococcus, which is a community acquired pneumonia. So we will look at the different antibiotics used to manage pneumonia. So the first antibiotic is community acquired pneumonia with no other problem and with no history of antibiotic. If a patient present to your clinic or present to an hospital, outpatients with signs of community acquired pneumonia, or has been diagnosed with community acquired pneumonia with no other problem or with no other history, these are the drugs you will keep. You will keep macrolides, which include azithromycin. It includes also clarithromycin. It includes also erythromycin. We have factosomycin. We have lelithromycin, or you can keep doxycycline. Doxycycline belongs to a class of antibiotics which are tetracyclines, and it's a protein inhibitor. So when it inhibits synthesis of proteins, it will mean it will reduce the growth of bacteria. So those are the different types of drugs you will keep at outpatient or at a clinic when a patient presents with the signs of pneumonia with or with no problem, with no other problem, or with no history of antibiotics. What about a patient with a community acquired pneumonia with a problem like asthma? Some patients who are asthmatic and they have pneumonia, or they have cancer, or they have diabetic mellitus, or they have kidney problem, or they have spleen problem, or with an history of antibiotic. These patients have a problem and they have community acquired pneumonia. Also, they have a history of antibiotic. What will you keep? You will keep respiratory fluoroquinolones, that includes ciprofloxacin. We have levofloxacin, moxifloxacin, ofloxacin, and the diafloxacin. So it depends with which type of antibiotics which are present in the facility you are. You can give those fluoroquinolones. Also, you can give a macrolide or tetracycline, doxycycline, tetracycline, which is doxycycline with a high dose of amoxicillin or augmentin. So if there is no fluoroquinolones around, you can give a macrolide, or you can give doxycycline with high dose of amoxicillin, which is amoxil mostly, or augmentin, or with a generation cephalosporin. The common one is ceftriaxone, which is F. So it will depend. If you miss fluoroquinolones, you have high chance you can see if there is any microlide, azithromycin, erythromycin, or if there is no those drugs, you see if there is a cycline. Whichever the one, you can keep with high dose amoxicillin, which is amoxil, or you can keep with augmentin. If these three are missing, you can keep an injection of ceftriaxone, which is a cephalosporin drug. So those are the different management of patient who has asthma, community acquired pneumonia with asthma, or cancer, or diabetic mellitus, or spleen problem, or history with antibiotic. So you must remember that if there are proquinolol, you keep proquinolol. If there are no proquinolols at the setup, you can keep macrolide. If there are no macrolide with high dose of amoxicillin, or high dose of augmentin, or that cephalosporin, that's generation cephalosporin, or if macrolide is missing, you can keep with doxycycline with high dose of amoxicillin or augmentin, or that generation cephalosporin, and mostly probably is ceftriaxone. Another one is community acquired pneumonia with signs of deterioration, and these signs of deterioration include confusion. Some patients may present with signs of confusion, we have uremia, which is there is high urea level in your blood. We have respiratory rate increase and low blood pressure, diastolic blood pressure, and this has been classified as GAF 65. 65 means a patient who is age 65 years and late. So GAF is a formula. You will remember this is C is for confusion, U is for uremia, R is for respiratory rate, which is increased respiratory rate. Also, B is for blood pressure, which is low. Diastolic pressure 65 means the patient is above 65 years. So, if if they have one of the signs, if a patient present with this one of these signs, with these signs, if they have one of these signs, you see, if they have one of these signs, you will give antibiotics as previous, as cup with asthma or any other problem, or with history of antibiotic, which was you keep fluoroquinolones. If fluoroquinolones is missing, you keep macrolide, which may be azithromycin or erythromycin or clarithromycin, whichever the macrolide, with high dose of amoxicillin or with augmentin. And if augmentin is missing, you keep that generation cephalosporin, which is probably subreaction because the most common. If that is missing, you keep doxycycline with high dose amoxicillin or augmentin or that generation cephalosporin. So you manage if they have one sign. If maybe a patient can present with confusion, you will manage as the previous, which is cup with a problem or with history of antibiotic. So that's the first one, and you can observe the patient and discharge home. So remember, the previous two was outpatient. You will not admit the patient. So second, if the patient have two of the signs, let's take for example, patient comes to your facility with a sign of dissociation, which include confusion, increased heart rate, confusion, and increase rate, there is increase respiratory rate. So what will you do? You will admit the patient. First thing is you admit the patient, and then you keep respiratory fluoroquinolones as we have seen with macrolide with so you will keep fluoroquinolones or macrolide with ampicillin. So now you will change. You will not keep amoxicillin or you will not keep augmentin here, but you will give ampicillin or ceftriaxone, which is a third generation cephalosporin. So you admit the patient, you keep fluoroquinolone. If fluoroquinolone is missing, you keep macrolides. If you have macrolide, you can give with ampicillin and or ceftriaxone. If the patient, if you have setup doesn't have macrolides and have fluoroquinolones, you keep with ampicillin or ceftriaxone, and probably IV, so that we can have a faster response. So if the patient have three of these signs, let's say for example, the patient presents to your facility with confusion, there is increased athlete, you take PV, there is low diastolic blood pressure. What will you do? Admit the patient at ICU. So when after admitting the patient in ICU, keep the subreaction plus azithromycin, that's a macrolide or pronoquinolone. So you keep subreaction plus pronoquinolones or plus ampicillin, and you had a surfactant plus a macrolide. So you see, all these are high dose of antibiotic because you keep sex reaction plus azithromycin or fluoroquinolones, or you keep ampicillin plus surfactant, and you had macrolide also or abronoquinolone. So you have two choices here. You can keep the reaction plus azithromycin or fluoroquinolones, or you keep ampicillin plus surfactant plus a macrolide or a fluoroquinolones. And you know that some patients are allergic to penicillins. What will you do? You need to be careful for those patients who are very allergic with penicillin sometimes, because those patients can react, and the end results may not be good at all. So it's good when you're managing a patient with these penicillins, you be more careful, because some at around 2% to 10% of patients are very allergic to penicillin. So what will you do when a patient is allergic to penicillin? You just keep as a monofactum, and preferably what we call citronam. So citronam is a prepared one when a patient is allergic to penicillins. So it's kind of beta-lactamase, which is monofactam. So that's the preferred one when a patient is more reactive to penicillin. So you need to remember this management so that you can manage pneumonia probably. You can have a patient who has acquired community-acquired pneumonia with with no other problem, or with history of no history of antibiotic. You give macrolides and you can discharge the patient, or you give doxycycline, which is a protein inhibitor, and when protein has been inhibited, it will reduce the growth of bacteria in your body. Another thing is a patient if presents with history of chronic disease or other problem like asthma, cancer, or diabetic, what will you do is you will keep a bromoquinolone, or you give a pronoquinolones such as levofloxacin, monofloxacin, and also you can give a macrolide or a doxycycline with high dose of amoxicillin or augmentin or third generation. What about the patient with deteriorating signs? You can give the first one is you can keep if they have one sign, you can give the same as GAP with problem or history of antibiotic and discharge them. If they have two, you need to manage at hospital, and you keep fluoroquinolones plus or plus you can keep macrolide with ampicillin or ceftriaxone. And if you have three, you can admit at ICU and you keep ceftriaxone plus azithromycin, or you keep fluoroquinolone or ampicillin plus a surfactant. So here you have two drugs. You can give ceftriaxone plus azithromycin, or you can give fluoroquinolone or ampicillin plus a sulbactam, and you add a macrolide here, or you can add also fluoroquinolone in this management. And when a patient is reactive to penicillin, you can give what we call monofactam, and probably what we call acetronam. So and you must note that patients should be responding to this management in day 1 to 2. A patient should be responding, and these signs of deterioration should be subsiding. So the duration of management here should be more at least 5 days. So that is it. So what if a patient presents with what if a patient presents what if a patient presents as Pseudomonas aeruginosa? You will keep Sosin, which is a biberacin. Also, Sosin is our example is a biberacin. It's a kind of a beta lactamase, which is extended. It's an extended beta lactamase. So you keep Sosin if they have a Pseudomonas, or you can give Cevivin, or you can give meropenem, hebenem. These are a class of antibiotic called, which are very strong, and they are called gabevenem. So gabevenem, we have meropenem, himevenem. So you can keep also. If you keep a level or citro, you must add macrolide. So you should think of adding a macrolide if you keep fluoroquinolones in managing Pseudomonas. If there is a community acquired pneumonia with methicillin, Zook, Staphylococcus aureus, which is a very resistant to antibiotic. You can give vancomycin or linezolid. So these are the drugs when a patient have a community-acquired pneumonia with MSSA. So that is it. You give vancomycin or linezolid. Because earlier on we saw that Staphylococcus aureus is a class of antibiotics that are very resistant to antibiotics, and when a patient have community-acquired pneumonia with methicillin, Zook, Staphylococcus aureus, which is called MSSA, you give vancomycin or linezolid too. These are management of community-acquired pneumonia. So let's go to hospital-acquired pneumonia. So hospital-acquired pneumonia, it should it has an early onset of 2 days, but not it has an early onset of 2 days and greater than 5 days, and not and less than 5 days in hospital with no drug resistance. So hospital acquired pneumonia is 2 days after admission, but less than 5 days in hospital with no drug resistance. So here you give IV ceftriaxone, you can give unacin, which is beta lactamase. Also you can give fluoroquinolone, you can give etabenem, which is falls under the class of carbapenems. So if as late onset of hospital acquired pneumonia, which is greater than 5 days with multi-drug resistance pathogen, you keep aminoglycoside, that is gentamicin, or fluoroquinolones. So you can keep fluoroquinolones or you can keep gentamicin. Uh, One of these keep you with you keep with sosin. So you add sosin, or you add carbapenem, which is meropenem, or you add cefivin. So if you keep macrolide, which is gentamicin or fluoroquinolones, you must add whichever the one here, you must add sosin, or you add carbapenem, which includes meropenem or cefivin or cefdazidine. And this is the management of late hospital acquired pneumonia, and that's a pneumonia that develops after 5 days uh, of admission, or also as a multi-drug resistant pathogen. So you keep those drugs, while the previous one was early onset of hospital acquired pneumonia, that's greater than 2 days and less than 5 days of admission, because we said community acquired pneumonia is a pneumonia developed at home, or less than 4 days days at hospital after admission. So so you see, we have different types of hospital acquired pneumonia. So this is how you go about when it comes to management. So let's proceed to see other. If there is a pseudomonas plus, you pseudomonas, you give sosin with levo or IG aminoglycosides or azithromycin or meropenem or ivermectin. So if there is a pseudomonas positive, you give sosin with levofloxacin, or with aminoglycoside, or with azithromycin, or with meropenem, or with ipemenem. So whichever the drug you will use, or whichever it will be available in your facility, but the key principle is to remember sosin is the one, and you use sosin with levo, and then you use which drug you will add on that to manage if there is a pseudomonas. Management of hospital acquired pneumonia is 14 days, and is to give room for um, if there is if there is Pseudomonas positive with what we call MRSA or MSSA, you keep vancomycin or linezolid, because we have seen methicillin, sugu, staphylococcus aureus are very resistant. You give vancomycin and linezolid. So this management goes up to 14 days, because some of the bacteria are very chronic and are very resistant to drugs, is to give room for antibiotic to function into our body. So you should remember that. Let's proceed. So let's proceed. So let's see prevention of pneumonia. We have some two types of vaccine currently which can be given. We have VVSV 23, and 23 stands for the 23 polysaccharide antigen on the bacterial, on pneumococcal bacteria. So it's called pneumopolysaccharide vaccine 23, pneumopolysaccharide vaccine 23, and 23 stands for polysaccharide antigen or pneumococcal bacteria. So it's very effective, 85 to 90% in invasive streptococcus pneumon. So if the patient have invasive streptococcus and pneumonia, you can give this, and is very effective to prevent it. You give the patient who are greater than 65 years of age, or 2 to 6 years, or those with comorbidities, e.g. HIV and AIDS, diabetes, sickle cell, etc., asthma, those chronic diseases, multiple sclerosis, any other chronic disease. You give this you can give this vaccine, which is VVSB 23, and we have seen 23 stands for 23 polysaccharide antigen on pneumococcal bacteria. So and it's effective 985 to 90% on invasive streptococcus pneumoniae, and you give to patients who are age 65 or to 6 years of age, or they have different comorbidities, e.g. HIV and AIDS, DM, sickle cell, or patient with 18 years, 19 years of age, sorry, with history of asthma or smoking. If a patient has history of smoking or asthma, you can give this vaccine. But generally, we don't keep to people who fall under this bracket of age above 6 years and below 55 years with no 65 years with no comorbidity or with no history of smoking. So that is it. Well, another one we call VCV13, VCV13, where 13 stands for 13 antigens on Streptococcus pneumoniae. We give to patients who are less than 2 years of age, and you keep at an interval of 2, 4, 6, 12 to 15 months. So that's the interval. And also you can keep VCV, then after 8 months you keep VVSV23. And if you keep VVSV23 first, you will need to wait for 1 year before giving VCV13. So these are the two vaccines that are available. Let's see the complication of pneumonia. And the complication here, it includes septic shock. We have pleural, because we saw that there was a lot of fluid in your alveoli region, so it will cause pleural effusion. We have meningitis, we have abscess, we have hypoxia. Hypoxia is the tissue start dying, or brain will start to die because of low perfusion. So these are the worst signs or worst complication of pneumonia, and include septic shock, pleural effusion, meningitis, abscess, and hypoxia. So I think you enjoy these videos, and till next time, hit subscription button, hit like button there, hit the comment section, and we move together as one.